Hello, good day everyone. My name is A.samy. I'm here to present the case of Mr. A.W. Mr. A.W. came to the clinic seeking secondary prevention for cardiovascular disease post non-ST elevated myocardial infarction treated by cabbage 6 months prior to patient visit. So the history of present illness for Mr. A.W. He's 56 years old, was known to have non-ST elevated myocardial infarction treated with cabbage 6 months prior to this visit, which was dated November 5th, 2018, requesting medication refill and looking for medical care to improve quality of life in his current, and he has no chest pain currently since surgery, and he walks 10 minutes 3 times weekly only, consume fast food and red meat, partially complied with his medication as he sometimes forget his bedtime bills. So his physical examination, he's a class 1 obese patient. His body mass index is 33 kilogram per square meter. His blood pressure is 164 over 92 and 160 over 88 on repeat. His lab results, his HbA1c is 9.4%. His random glucose is 210 milligram per deciliter. His fasting LDL 140. His cholesterol 219, and his triglyceride is 180 milligram per deciliter. Mr. A.W. Bast's medical history, as we said before, he suffered from non-ST elevated myocardial infarction, hyperlipidemia 3 years back, and type 2 diabetes 3 years back, and several attacks of headache. Mr. A.W. is allergic to penicillin, and the current medication he is on is metformin 500 milligram PID, carvedilol 6.25 milligram PID, atorvastatin 10 milligram once daily, and ibuprofen 200 milligram, 2 tablets twice per day, multivitamin once daily, and also nitroglyceride 0.3 milligram sublingually, PRN for angina when needed. So we'll talk about his hypertension, as it has a very big impact on his case and how to protect himself from having a secondary attack. So as we said before, his blood pressure is 164 over 92, which is not controlled. So the medication adjustment is recommended for Mr. A.W. to target 130 over 80 millimeter mercury using standard routine clinician office measurement, and also if we can use also the arm blood pressure monitor should be between 120 and 125 over 80 millimeter mercury. So the recommendation is to have to maintain carvedilol 6.25 milligram PID, also to add captopril, start with 25 milligram orally PID, and titrate the dose up once needed. Rationale of this: the recommendation is supported by randomized clinical trial and meta-analysis, such as ACCORD, which is the largest trial tested the blood pressure control in cardiovascular patients. It showed that intensive control of blood pressure in the standard glycemic control group was associated with fewer major cardiovascular events. So, beta blockers in patients with established cardiovascular disease reduce morbidity and mortality as a consequence of blood pressure reduction, and also reduce heart rate. Carvedilol used as preferred in cases of metabolic syndrome because it has a favorable metabolic and tolerability profile comparing to older traditional beta blockers. Having said that, combination therapy is required in this case, as we mentioned before, and according to the Niskan et al., 572 out of 10,985 hypertensive patients with diabetes mellitus between 25 and 66 years with diastolic of 100 millimeter mercury found that cardiovascular morbidity and mortality was marked lower in the captopril than in the conventional group, which is basically diuretic and beta blockers. So, and also we need to educate Mr. A.W. regarding the side effects he may encounter at the beginning of the treatment, basically dizziness and some peripheral edema if it happens, and also ACE-induced cough. And we need to emphasize actually in his blood pressure check, should be checked daily, and to check also if there is any dizziness, he has to contact his healthcare professional right away. And regarding his forgetting pill at night, I think one of the good tactics we can use is basically using blister back for him, so that will definitely help him to remember his medication at night. Secondly, we're talking now about his dyslipidemia, as it's one of the major rules of the atherosclerosis cardiovascular events. As we said before, Mr. AW has prescribed atorvastatin, 10 milligram once daily, which is very low dose for his case. And so the recommendation is to increase his dose to 40 milligram once daily for 4 weeks, then evaluate lipid profile. It should be, the LDL cholesterol should be 70 milligram per deciliter, and then we maximize the dose to 80 milligram per day. It should be less than 70 milligram per deciliter. If the side effects are not tolerated, consider combination with ezetimibe. The rationale, according to the American Heart Association 2008 recommendation, it's considered with the very high-risk group, previous atherosclerosis cardiovascular coronary disease 6 months ago, and positive history for diabetes. Additionally, his total cholesterol level is 210, which is classified as a severe hypercholesterolemia. Accordingly, high-intensity statin therapy should be initiated to achieve 50% or greater reduction in his LDL. Therefore, maximizing statin is recommended. Moreover, high-intensity statin therapy should be initiated for men and women less than 75 years of age with atherosclerosis cardiovascular symptoms. Randomized trials of LDL-lowering drugs, including statin and ezetimibe, have shown a reduction of cardiovascular events. However, it did not show any mortality benefits. And the patient has to be educated to take care of the side effects he may encounter from the drug, and also to be sure that to be aware that there's some experience fatigue and muscle pain, and the patient actually should consult his healthcare professional if this case gets worse. And avoid grapefruit juice, as grapefruit juice actually may increase the level of his atorvastatin in the blood, which may increase the incidence of having side effects. Now we'll talk about his diabetes mellitus. As we said before, the patient has HbA1c 9.4%, and according to the results, this is hyperglycemia, which needs to be addressed. Recommendation: we need to target HbA1c between 7 to 8, average 7.5, increase metformin dose to 500 milligram from 500 milligram PID to 850 milligram PID, and also to make lifestyle modification and weight management for the patient weight. The rationale of that is standard glycemic care has better prognosis than intensive control, according to a core trial which includes 10,251 patients with long-standing type 2 diabetes. So stopped after 3.7 years due to increased mortality among the group of intensive glycemic control, which we are not aiming to do today, comparing to standard glycemic control group, which is basically 7.5%. And then we need to make a follow-up. So if the patient actually stayed above 7.9, despite of the weight management, metformin, dose adjustment, and lifestyle modification, after 3 months of treatment, so we may need to add one more medication as biglitazone or sulfonylurea, and I think in his case sulfonylurea would be more appropriate, glycoside 30 milligram. And also we need to educate patient about hypoglycemia, which I don't think is going to be the case here, as the medications, if it's glycoside, will definitely be less likely to have hypoglycemia. So the other factors that really negatively will affect his established heart disease and comorbidity, first, of course, the obesity, and the second, sedentary lifestyle, consuming fast food and red meat, consuming non-steroidal anti-inflammatory drug for recurrent headaches, which he is facing. So to improve the quality of life and prevent any future CV events, the patient should undergo adding antiplatelets in case of non-ST elevated myocardial infarction. So the dual antiplatelet therapy is recommended for 12 months, and AW is still having 6 months window to benefit from dual antiplatelet therapy. So we can add aspirin 81 milligram once daily and clopidogrel 75 milligram daily. The rationale of this is on average follow-up for 9 months dual therapy can reduce primary endpoints cardiovascular death and non-fetal myocardial infarction or stroke, which is 9.3% versus placebo group with 11.4% as per Q trial. For that actually was a trial was done on 12,562 patients with acute coronary syndromes, randomly assigned to clopidogrel or placebo in combination with aspirin. Lifestyle modification, diet change. Fast food can provide high amount of sodium, which will increase blood pressure. According to the American Heart Association guidelines 2013 on lifestyle modification to prevent cardiovascular disease, adults might benefit from diet changes to lower their blood pressure as follows: consuming more vegetables, fruits, and whole grains and fish, limit intake of sweet, sugar, weekend beverage, and red meat. That is grade A strong recommendation. Lower sodium intake, grade A again, no more than 2400 milligram of sodium per day. Target is less than 1500 milligram per sodium per day. According to 2013 American Heart Association guidelines, an increase in the physical activity can reduce LDL from 3 to 6 milligram per deciliter, moderate evidence. Lower blood pressure by 2 to 5 over 1/4 millimeter mercury, high evidence. One of the suggested regimen is average of 40 minutes of aerobic exercise, brisk walking for at least 3 days a week for at least 15 weeks for the change to occur. So also we need to educate the patients that gradual increase of exercise intensity is advised at the beginning of avoid the straining on the heart. Obviously, we need to observe any symptoms of shortness of breath, chest pain, stop exercise immediately, use nitro spray, and ask for help after 3 sprays by 911. Weight management, as we said before, according to the American Heart Association guidelines 2013, can positively affect the quality of his life by reducing 3 kilograms of his weight is an average reduction of 15 milligram per deciliter in his triglycerides, while 5 to 8 kilogram weight loss can achieve 5 milligram per deciliter on his LDL and 2 to 3 milligram deciliter in his increase in his HDL. In overweight and obese adults with a diagnosis of diabetes type 2, reducing weight by 2 to 5% with or without orlistat reduce the risk of developing type 2 diabetes by 30 to 60% high strength evidence. Okay, so now headache. Regarding headache, we need to address causes of headache. What was the main reason for that? Meanwhile, switching from ibuprofen to acetaminophen to control the headache, and we can maximize the dose up till 4 grams per day, which is 8 tablets of the 500 milligram per day. The rationale is non-steroidal anti-inflammatory can cause an increase in blood pressure and accelerate kidney damage in case of diabetes. And lastly, of course, as the patient is hypertensive and diabetic and suffered from an attack before, so influenza vaccine according to guidelines, that definitely is going to minimize his flu attacks during the flu season. So he needs to get the annual influenza vaccines, and that's class A level of evidence B. Thank you very much. The references is available for review, and have a wonderful day. Thank you.